Um, my research questions were, as the decriminalization of the possession of all drugs, as implemented in some countries, reduce the harms experienced by drug users by reducing criminal proceedings against them, by improving care for them. And my objective was to identify the factors which improve or reduce the benefit of this legal framework for drug users. You have two ways to decriminalize. Decriminalization can be de facto. While remaining a criminal offense, possession is not criminalized in practice due to a directive to local prosecutors given by the government, as is the case in the Netherlands. Decriminalization can be de jure. The offense is removed from the criminal code and transferred under the jurisdiction of an administrative authority. This is the case for most of the countries. And you have also two decriminalization model. Decriminalization of drug possession can be done without applying any other sanctions to replace criminal sanctions, or by imposing non-criminal sanctions such as community service, fines, and mandatory drug education programs, for example, which is the approach taken by most countries that have done this. The methodology I use. In this research, only countries that have opted at the national level for the decriminalization of possession of all drugs were selected. But some countries entering this niche have been excluded due to a lack of access to sufficient data. That was the case for Chile, Croatia, Estonia, and Paraguay. Moreover, Russia was not taken into consideration because the researchers agree that Article 228 of the Criminal Code, which is relevant in this regard, is not being enforced. Countries part of this study: in Europe, Italy, Netherlands, Spain, Poland, Czech Republic, Portugal, and Germany. In Latin America, Uruguay, Costa Rica, Peru, Colombia, Brazil, Ecuador, Argentina, and Mexico. For each country, the influence of the political, social, economic, legal, and judicial context in which this choice was made was taken into consideration. Let's show the findings. First finding: almost all governments which have chosen this legal framework de jure deem it necessary, in parallel, to increase considerably penalties for trafficking and drug possession for the purpose of trafficking. The reasons are related to the debates in Parliament that make it necessary for the government to send a message to the population afraid by the prohibitionist discourses of the opposition parties that their intention was not to be soft on drugs. Exception in this regard is Portugal and Germany in Europe, and Uruguay and Costa Rica in Latin America. Second finding: for the same reason than the first finding, in the jure decriminalization, the government has to set amounts of drugs that qualify as simple possession to reassure the population. These amounts are often very small to please the opposition parties. As a result, a number of users now end up in the criminal justice system with heavy sentences in cases where penalties for possession for the purpose of trafficking were increased. The situation is particularly acute in Latin America. Third finding: the prohibitionist context has led to the adoption of administrative sanctions instead of criminal sanctions by most of the countries which have implemented this decriminalization. It was a way of emphasizing that drug use remains socially unacceptable. Fourth finding: after decriminalization, in many countries, the prohibitionist policy context also creates a situation where, when drug scandals are reported in the media, creating public pressure for harsher drug conviction, or when the situation is otherwise exploited for political gain, and whenever law and order governments come to power, these policies are quickly changed or diluted to the point where they become meaningless. Fifth finding: access to care and harm reduction strategies do not automatically follow the decriminalization of simple possession of all drugs. It would be more accurate to say that decriminalization of possession enhances the possibilities for harm reduction strategies and care for users only when governments choose to make the required investment in this direction. The Portuguese exception. When it comes to improving care, implementing more harm reduction strategies, and reducing repression, Portugal is an exception. This can be explained in part by the fact that from the outset, the debate on decriminalizing simple possession and expanding care for drug users is part of a global health policy on drugs sustained by three key sectors: justice, healthcare, and policymakers. Discussion. For Latin American countries, while a number of Latin American countries have decriminalized simple possession for all drugs, or are considering doing so, one should not expect too much of a decrease in repression if this decriminalization doesn't go hand in hand with putting an end to parallel justice systems in matters of drug offenses, which are very repressive and diminish corruption of the police or other officials. For Europe, when it comes to European countries, our research shows that as users continue to be viewed negatively, when high profile drug scandals are exploited politically or right wing governments come to power, the amounts constituting possession are lowered in the law, and public disorder and minor drug offenses associated with drug use are punished more severely. What are the necessary conditions for this legal path to become a positive step towards less criminalization and more care and harm reduction strategies? First, in the legislation, simple possession should be defined as any possession of drugs for a purpose other than trafficking as a lucrative activity, rather than an arbitrarily fixed amount which does not allow for recognition of all personal use. This would prevent amendments aimed at reducing the amounts of what constitutes possession in the context of conservative shift in the political landscape or as a political response to public concern over high profile drug scandals. Second condition: no alternative sanctions should be applied, fines, community service, etc., for simple possession, because sanctions, whether criminal or administrative, maintain the stigmatization of drug users and leave room for calling decriminalization into question. Third condition: in the field, the police should be given clear guidelines enabling them to make decisions to help users avoid criminal prosecution, especially pretrial detention, before determining whether it is a case of simple possession or not. It is important to spare users the criminal proceedings and especially criminal records. Fourth condition: if users experience problems, they must not be subjected to forced treatment as a substitute for sanctions because they may not be ready to undergo treatment, which is then likely to be ineffective, or submit to treatment only to avoid sanctions and not because they need it. It is better to accompany them so as to reduce the risk of drug use related harm. Fifth and last one condition: in cases outside the scope of simple possession, criminal sanctions for possession for the purpose of trafficking must distinguish between degrees of market participation and whether or not violence was involved. On one hand, This is necessary in order to maintain the proportionality between sanction and offense. On the other, problematic drug users must be taken into account because participation in the market may be a matter of survival due to their addiction. Conclusion: putting these conditions in place would greatly facilitate the eradication of stigma against drug users and, by the same token, provide a political justification for providing care services and implementing more harm reduction strategies. Thank you.
Thank you so much, Lynn, for these extremely concise, clear, and striking findings and observations. We now move to the second panelist. It's Stephanie Arlt. She's a master's student in the program of Social Dimensions of Health at the University of Victoria. And her paper is entitled Problematizing Safe Consumption Sites, a discourse analysis of Ontario's consumption treatment site policy.
Thanks, Marie. I'm going to share my screen. Okay, so hi, everybody, and thank you for joining us for the Drug Regulation Policies and Strategies panel. My name is Stephanie, and I am grateful to be presenting from the Coast Salish territories that include the Lekwungen, Esquimalt, and WSÁNEĆ nations. This presentation is about how the 2018 Consumption Treatment Service Reform in Ontario problematizes addiction, safe consumption sites, and the people who use drugs. My research looks at how dominant cultural ideas about people who use drugs are translated into public policy and that impact on healthcare provision. The CTS policy reform was announced in the first year of my master's, and it ended up becoming the focus of my thesis because of its substantial ideological nature and my curiosity as to what that meant for healthcare provision and the cultural representation of people who use drugs. This presentation gives a brief overview of the ideological values present within the CTS reform. So in Ontario, the election of the Progressive Conservatives signaled a change in drug policy. The PC government announced a review of safe consumption sites. The review, which was communicated in the two reports named on the slide, concluded that safe consumption sites would be remodeled as consumption treatment services and proposed that the sites would require the changes identified in the review process. The suggested changes and the premises in which they are formed are considered to be largely ideological and anti-harm reduction. This wasn't very shocking, given that during Doug Ford's campaign, he said, "I ask anyone out there, if your son, daughter, or loved one ever had an addiction, would you want them to go into a little area and do more drugs? I'm dead against that." The reason I included this quote is because I think it sets the tone for why policy as discourse is an appropriate analytical framework for the CTS reform. So the paper has analyzed the CTS reform policy proposal as it's been communicated in the media announcement, because when considering discursive representations of a problem, how it is framed for consumption by the media is a significant starting point. Carol Bacci's What is the Problem Represented to Be policy analysis framework comprises of a set of 6 questions, which are outlined on the next slide. A central component to the policy as discourse analysis is that it views policy proposals as productive, meaning problems are constructed and defined within the proposal rather than just responding to problems that are already out there. This means that policy proposals legitimize and regulate shared knowledge of a social phenomena. The point of this analysis is to demonstrate how that occurs by critically interrogating what Bacci calls the taken for granted truths, which are entrenched cultural and political beliefs that the policy is predicated on. The application of the What is the Problem Represented to Be framework to the CTS reform leads me to ask, how is addiction, safe consumption sites, and people who visit safe consumption sites constituted as a problem within the CTS policy proposal? So here we have the 6 questions that the analytical model is comprised of. I will go through questions 1 through 4 as part of the analysis, and then questions 5 and 6 frame the discussion. So what is the problem represented to be? And while there are multiple problems represented in the policy, I couldn't fit them all in under 15 minutes. So I chose what I thought was the most salient. And the foremost problem conceptualized in the policy is that of addiction. So the proposals focus on addiction rather than drug use per se, situates the representation of the problem as one of pathology and then in the domain of medicine. The overdose crisis is chalked up to be a problem of addiction where treatment and rehabilitation are the logical solutions. It's important to note that within the policy, treatment is coded to mean abstinence-based care. The emphasis on treatment, aptly demonstrated by the name change to consumption treatment services, assumes an inherent medical condition associated with people who visit safe consumption sites. And while this is not necessarily incorrect, Beauchesne argues that problematizations reduce the complexity of social phenomena into digestible pieces. On this side, we have an example of one of the many passages within the proposal that characterize the problem of one that requires medical intervention, increased medical intervention. So what are the presuppositions or assumptions that underline the representation of this problem? There are two assumptions that drive the representation of this problem. The first is the assumption that safe consumption sites are trying to solve addiction and that ending drug use should be the primary goal of the site's operation. Within the policy proposal, safe consumption sites are not considered to be effective healthcare services if they do not encourage the succession of drug use. This assumption comes from the rhetorical speculation that safe consumption sites encourage drug use and therefore enable addiction. The second assumption is that the increased medicalization of safe consumption sites will rectify the service's inability to produce abstinence service users. So where do these assumptions come from? First, there are competing and often partisan models of knowledge present within the discourse of addiction in Canada. Some will argue that using drugs is what causes addictions, while many others argue that people use drugs and never become addicted. And the proponents of this position emphasize it's about social conditions that lead to harmful substance using patterns. Within the CTS policy, drugs are considered the starting point for intervention and represented as a catalyst to addiction. One of the concerns in solely applying a medical model of drug use is that it limits the ability to understand the continuum of drug use, which in turn compromises ideas about human agency in favor for theories of compulsory behaviors. And while it is out of the scope of this presentation to detail the rise of the medical model, the representation of the problem has come about by decontextualizing the medical aspect of addiction from the social and environmental factors. What is left unproblematic in this problem representation, and where are the silences? The silences within a policy proposal are noteworthy because when certain factors aren't mentioned, they're assumed to not play a significant role in the problem. And the first silence is a lack of reference to the social determinants of health in the context of addiction. While the policy only briefly mentions inadequate housing support, it does not significantly consider or even mention many of the environmental factors which have been demonstrated to contribute to addiction. Second, which I think is the most glaring silence, is that the drug supply has become increasingly toxic, which is the #1 cause to overdoses. In 2018, 74% of opioid-related overdoses involved fentanyl or fentanyl analogs. This is data for Ontario. This silence serves to echo the consumption of drugs is the starting point for the problem, reinforcing abstinence treatments as the solution. The final silence lays in the minimization of the numerous successes that safe consumption sites have had in connecting people with a variety of services. This is less of a silence and more of an overt misunderstanding of the function of safe consumption sites, because since their inception, safe consumption sites have connected people to health and social services. But since the site's overall framework isn't abstinent-oriented, these successes are considered secondary, with the perceived primary goal of abstinence being unmet. And while the CTS policy recognizes the safe consumption site's impact on reversing overdoses, they frame the task of connecting people to other social and health services as something that is new within the CTS model. So in addition to this mischaracterization, a detrimental silence is the lack of recognition of the successes of peer-run sites, which in turn minimizes and discredits the contribution of people who use drugs in advancing healthcare and reducing drug-related harms. So In my discussion, I seek to answer what are the effects of discursive and subjectification that are produced by the representation of this problem. As of now, I can't speak to the lived effects, but I'm hoping that my thesis research can shed some light on this. The first is the discursive representation of people who use drugs as the other. And this is achieved through numerous references to safe consumption sites, visitors, impacts on the communities in which safe consumption sites exist. What is great about safe consumption sites is that they provide a contact point for the community residents to seek healthcare services and social workers in an attempt to improve their quality of life. However, demonstrated by the passage on this slide, there's an assumption that the people who visit safe consumption sites fall outside of the local residents. The second discursive theme is that abstinence is best practice. In the documents, treatment is referred to 16 times and rehabilitation 6 times. The reality constructed within the consumption and treatment service model prioritizes abstinence-based models of care, while delegitimizing harm reduction models and undermining the role safe consumption sites play in supporting both safe use and abstinence. Within the policy, the value of these services are measured only within the capacity to enable individuals to seek addictions treatment, which leads me to the subjectification effects. So subjectification is the process in which the self is defined, acted upon, and regulated. The emphasis on abstinence constructs a subject as incomplete in the process of waiting to be fully realized. With treatment being positioned as the ultimate solution to addiction, the CTS policy constructs people who use drugs as pathologized with the subjective results of deviance, especially in relation to other community members. The deployment of an us versus them dichotomy insinuates that people who use drugs are not seen to be community members, and that their needs and concerns are to be held in contrast to the needs of a community who fears an assumed risk associated with the presence of illicit drugs. The consequence is a cultural exclusion that minimizes the benefits of full and equal citizenship and a person's right to access healthcare services. The CTS policy claims a relentless pursuit on rehabilitation, which suggests that an individual who uses drugs' quality of life is only valid insofar as they are willing to achieve abstinence, and a safe consumption site's recognition as a healthcare service is only valid insofar as it promotes that goal. So this analysis has identified values and assumptions within the CTS policy that contrast harm reduction philosophy. The press release documents irresponsibly problematize safe consumption site visitors while reducing the complexity that is the overdose crisis to just the problem of addiction. In turn, the policy rejects the best available scientific evidence in favor of common and simplistic ideas around drug use at the expense of the population amid an epidemic. And this is, I'm still working on my thesis. So if you are someone who works at a safe consumption site who has worked before and after the CTS change, and you would like to be interviewed about your experience, you can contact me at my email below. And then here are my references, and thank you. And that's my Twitter handle. You can follow me if you want to hear more from me.
Thank you so much, Stephanie, for a super interesting paper and project. And we now move to our third and last panelist, Matthew Bonn, who is the program coordinator of the Canadian Association of People Who Use Drugs. And his paper is entitled Addressing the Syndemic of HIV, Hepatitis C, Overdose, and COVID-19, the Potential Roles for Safe Supply and Decriminalization. Matthew?
Thanks everyone for having me, and thank you for the two speakers before me for really setting the tone for this, hopefully a really fruitful conversation around decriminalization. Before I get started, I just want to, first, I guess my affiliations, as I said, I'm the program coordinator of the Canadian Association of People Who Use Drugs. I'm also a national board member for the Canadian Students for Sensible Drug Policy. And really, because due to the COVID-19 pandemic, we recently just formed a Pan-American network of drug user activists, which we have representation from Canada, the US, Mexico, the Caribbean, and we're actually getting more representation from Mexico than we have in any other regions. And we just had somebody actually kidnapped by the police and forced into treatment, which is really bad in Mexico. And luckily, he just got released the other day. So, you know, acknowledging that even when drugs are decriminalized in certain places, unless there's really a person-centered perspective in the implementation of it, they're going to be deemed to fail. And and I'd like to acknowledge that I am presenting today from Mi'kmaq, the ancestral and unceded territory of the Mi'k people. This territory is covered by the treaties of peace and friendship with Mi'kmaq and the Wolastoqiyik signed with the British Crown in 1725. The treaties did not deal with the surrender of lands and resources, but in fact recognizes Mi'kmaq and Wolastoqiyik title and established the rules for what was to be an ongoing relationship between nations. Honoring this treaty relationship through land acknowledgement is just one of many steps that can be taken towards reconciliation as outlined in the 94 calls to actions issued by the Truth and Reconciliation Commission of Canada in 2015. I believe that every individual and every institution has a role in playing in making the needed changes to dismantle systemic racism and oppression against Black and Indigenous people in Canada. I think one action that anyone can take is raising your own cultural awareness, learning about other cultures, asking questions, reading, and becoming more self-aware. It may seem simple enough, but we have to go into this journey, being prepared to be humbled at any point. We will make mistakes. You know, as long as we have an open mind and an open heart, we will we'll get through it. And through this acknowledgement and the harm reduction philosophy, we commit ourselves to this lifelong work. So my paper, you know, is actually my first publication. I am someone who uses drugs. I actively use fentanyl on, you know, a daily, weekly, monthly basis. It really depends on my relationship with it at the time, but kind of being engaged in a lot of academic and scholarly work through advocacy, I got my first publication in the Journal of Studies of Alcohol and Drugs. And through that process, I'll speak a little bit more to it, but when we're talking about, you know, an overdose crisis, we're not just talking about an overdose crisis, and we're not just talking about a pandemic. What we're really talking about is a syndemic. You know, people who use drugs experience so many various health and social harms that, you know, the general public may not be aware of, right? We have, in Nova Scotia, I know we have approximately 300 new cases of hepatitis C every year, primarily amongst injection drug users, which is a lot. And we're trying to eliminate hepatitis C by 2030. And if we keep up with these rates, we will not eliminate it. We experience a lot of injection-related infections. You know, I've had people close to me die from endocarditis. In Nova Scotia, we have, just like the rest of Canada, you know, a mass incarceration problem, primarily impacting Black and Indigenous and African Nova Scotians. But, you know, I've been criminalized and put in jail for my drug use as well. In 2018, we had a spike in HIV. Approximately before that, like 2017 and before, we had approximately 14, 15 new cases. In 2018, it jumped to 29 or 30, 31. I've heard different stats. I think the official one's 29. That's just people who have been tested and diagnosed. And once again, that's primarily amongst injection drug users. And right now we are going through an extremely bad affordable housing crisis. The Liberal government quietly removed rent control. So we see huge rent increases over the last few years. And, you know, I say they're a Liberal government, but honestly, they're a very conservative government. So we're not just experiencing one public health emergency, we're experiencing many, and it is a syndemic. And, you know, I had no idea what a syndemic was until I really started to look into it. But, you know, a syndemic is, and I guess the hallmark of a syndemic is having two or more health or social issues interact with each other to negatively impact the trajectory of each disease progression. So like a prime example is being HIV positive, hepatitis C positive, and experiencing homelessness. So, you know, if you don't have stable housing and, you know, you're co-infected, you're a lot less likely to take your medication. Why? Because, well, one, you're homeless. You're probably going to be looking for a place to stay that night. You may be looking for food. You'll be looking for drugs. So, well, there's there's so many different ways that, social issues really impact the health outcomes. So, I like to reframe it as, we're not in a pandemic, we're in a syndemic. COVID-19 is a syndemic of many things. The first kind of syndemic kind of, I guess, concept was the substance abuse, and I hate saying abuse, but this is what it was: violence and HIV, the SAVA syndemic. And that's back into the late 80s and 90s, and arguably we're probably still in the syndemic today with a couple other extra components on it that are really impacting people who use drugs. The Lancet published a really great series, I believe, back in 2017, that really kind of gets into some of the more details about what a syndemic looks like and how we can go forward, committing ourselves to a healthier future. I think we really have to look at ways meeting the 17 UN Sustainable Development Goals to really treat people as people first and not because of what they consume. So to my slide, or my presentation is mainly around my recent publication. So a group of us, I guess I called a friend of mine, and I was doing a lot of freelance writing at the time, and COVID-19 just hit, and I realized, oh, I could do this in a medical journal, and I realized what I was getting into. But so I called my friend in Montreal. I said, how do you write a letter to the editor of one of these academic journals? And we kind of went through it. So this whole paper started as a 400-word safe supply letter to the editor, and we were aiming high. We wanted to get it in the Lancet. It really quickly got denied at the Lancet. I have some connections with the International Journal of Drug Policy. We soft submitted it there, and they recently just solicited a piece around a very similar thing. So they really kindly let us down. And then I remember back to when I wrote this article in The Conversation: Decriminalizing Drug Use as We Contain the Coronavirus is the humane thing to do. And when I shared it on Twitter, I had the Journal of Studies of Alcohol and Drugs, which is the oldest journal dedicated to solely alcohol and drugs, back to 1940. It's through Rutgers University. They reshared it, and they had a nice little comment. And I said, oh, I'd love to publish with you guys. Can you guys let me know how to go about it? And instantly I had an email from the editorial director. And I didn't really think anything of it. That was way before this actually kind of became a thing. And then, so when we were trying to find places to publish it, I said to my friend, why don't we just, I had this interaction with this online journal, and he told me it could have been a predatory journal. Anyways, it was a real journal. We soft submitted it, and the editor-in-chief got back to me, and he said, can you maybe take this 400-word letter to the editor, and we don't accept them, so can you change it into a different format, a perspective piece, including your thoughts on decriminalization? I said, sure. How many words? I'm a writer, I'm a talker, so really quickly gave me 1,000 words. And my team of co-researchers here, Adam Palu, Dr. Sophia Bartlick, Dr. Tommy Brothers, Natasha Tusnard, and Dr. Mark Tyndall. And actually Mark Tyndall kind of came in later on with it, but we kind of got together and started to, really, we were really happy that we had extra words, because it was 400 words is not that much. And so we really started to talk about, okay, this isn't an overdose crisis we're in a crisis of many things, and we all brought a different perspective. And I think all our voices were really heard in the publication, and it was really a proud moment for me. We also, in the acknowledgement sections, we did a land acknowledgement, which traditionally isn't done in academic publications. So I hope it's something that can catch on and really really acknowledge where we are meeting, who is disproportionately impacted by this syndemic. In addition to the publication, they actually solicited. I'll speak a little bit. So it was the potential roles for safe supply and decriminalization. So we took kind of the syndemic argument, and really saying that, the criminalization, and that's where it really stems for, really impacts people who use drugs. It affects their life, liberty, and security, and looking at innovative and sustainable ways of trying to get ourselves out of this syndemic, right? So, first of it was the decriminalization. We can't be criminalizing people, putting them into already over jam-packed facilities. Those are the types of environments where a pandemic like COVID-19 thrives. We have to do everything we can not to criminalize people. We do have, people like, I guess, organizations like the Canadian Association of Chief Police calling for the decriminalization of simple possession of illicit drugs. We've got the Canadian Prosecutor's Office calling for it. But, Justin Trudeau is heavy against it, and he doesn't want to be known as the decriminal or the drug prime minister, but, he really, I'm going to remember him as the prime minister to let this overdose crisis that continue to go on. And, arguably we're in the fourth wave of it. There's been three waves: the prescription pill crisis, the heroin crisis, the synthetic analog crisis, and now we're in the COVID-19 syndemic aspect of the overdose crisis, which is killing more people now than it ever has, with 179 overdose deaths in 1 month in BC. Like we have to really change our thinking on this. So, we have some traction, but, at the end of the day, as it was mentioned before, like these things can either be done through de facto decriminalization, which is not what we want, but they can also be done through an exemption signed by the Canadian Drugs and Substance Act, or through, regulation. I think when we're talking about decriminalization, we don't want to go off of the Canadian Association of Chiefs of Police. We really have to create our own framework of looking at what does decriminalization look like for us in Canada. And I really think we can be leaders in the movement. Everybody talks about Portugal and the Portugal model, but I'll tell you right now, the Portugal model is not the best model. People are still criminalized, they're arrested, they're put through the dissuasion committee, right? Like that can really impact somebody's life, liberty, and security, right? We have a lot of safe consumption innovations in Canada. So if we were to decriminalize drugs, and Oregon kind of beat us to it, but I think that we could be leaders in the field for the whole world to look at. And on top of decriminalization, we also need a safe alternative supply to the contaminated fentanyl supply. As Stephanie said, most overdose deaths now are by fentanyl or fentanyl analogs: carfentanil, methylfentanyl, acetylfentanyl. There's like 60 known fentanyl analogs, and there's like 600 unidentified fentanyl analogs. And as somebody who engages in criminal activity on a daily basis, I can tell you that the criminal organizations are way ahead of any governmental organization, and they're going to continue to produce stronger and more deadly opioids and other substances unless we come in and try to change that market. Right now, as drugs are still criminalized, the only kind of way we have through that is through a safe medical model. But if we're going to do that through a medical model, we have to do it through a low barrier medical model. Not everybody wants to be on IOT going 3 or 4 times a day clinic. Safe supply is meant to be able to take it and go home and use safely. If I know the quality and the quantity of the dose, I can use it safely. CAPUD has really been leaders in the field of safe supply. We have a safe supply concept document that was published in February 2019, probably one of the most cited academic grade literature sources. We have the risk mitigation guidelines in BC. Not perfect, but it's a great start. And I'm part of a team that's got a CIHR grant. I'm actually the lead. I'm a principal applicant, lead author on it, really looking at safe supply in COVID-19, but how do we sustain it afterwards as well? So from my journal of studies of alcohol and drugs, they actually solicited 3 commentaries for it. And I always get like a kick out of it because I'm just a drug user in Halifax, Nova Scotia that has no academic experience. And now, I got professors of Yale and Stanford and the University of California like commenting on my our literature. And not surprising, not all of them agreed, not all of them disagreed. You know, there was a lot of paternalistic abstinence-based language in a lot of the commentaries. You know, this one around partial agonists, which is probably the most progressive and on board one, but they were really arguing for, oh, well, we need Suboxone. No, we don't. We need heroin, cocaine, and fentanyl. That's the only thing that's going to get us out of this crisis, and we need to know that it's regulated and it's safe. You know, and then unsafe supply, they really, Anna Lembecki really kind of honed in on us on that. But the journal actually just green lit our response. So we're working on a respond to all these commentaries. And I'm really glad it's in a conservative kind of journal, like the Journal of Studies of Alcohol and Drugs, because this conversation needs to be had in the States. 8 people die every hour in the States, and that's insane. So in addition to the publication, I actually it received some media attention, which is pretty cool for, you know, my first publication. I really don't know what I'm doing. I like to pretend that I am, but it really has sparked my my interest, and I am a student now. I'm back in finishing my business of commerce degree, so I can go on and take different programs. But yeah, so Alexa McLean from Global News, who really actually helped advocate, or I guess she didn't really help advocate, but she did, like, she was a main journalist that helped for our overdose prevention site. But she reached out to me after we published, and you know, it was really interest around the syndemic piece of it. So I explained it to her, and she did a little piece on it, and she talked to Dr. Tommy Brothers and Dr. Mark Tyndall. You know, and it's been just such a pleasure working with you know, everybody on this research team, and I can really see it kind of like growing into something else. But you know, being able to get to work with Mark and, you know, discuss the MySafe machine and hopefully have one in Halifax one day, and Tommy, who is a really close friend of mine, and you know, has taught me so much. And you know, I think he would always say, oh, well, you taught me so much, but it really is a two-way street. People who use drugs learn from academic scholars, and academic scholars learn from people who use drugs. But we have to treat each other as equals and empower each other, right? And people don't realize how much privilege and power they have until they empower somebody such as myself, who Tommy and Adam and Mark, and they have all done that through this process. I don't know what time I'm at because I can't really see it, but I stole this from Mark. Well, I guess he stole it from Banksy. It's one of my favorite photos. I got a picture of it in my office. But you know, we really do need change. If we want to start to reduce this overdose crisis, we could completely look at it a different way. People need a safe supply of drugs, and we need to decriminalize people as well. They need a safe place to use and a safe drug to use. So you guys can keep your coins, but I want change. Thank you.
Thank you so much, Matt, for this super important paper, for sharing your expertise, and also for reframing the conversation. I think I had personally never heard of the word syndemic, so and I think it actually really describes well what's going on right now. So thank you so much for that paper. Thank you to all 3 panelists for amazing presentations, which really highlight the importance of the impact of political discourse and politics in shifts in policies and affecting some of the strategies and harm reduction strategies that we can put forward, and also the importance of research and politics in moving forward. So we're now opening up the floor to participants to ask questions. We already have a comment in the Q&A from Kristen to Matt, congratulating you for your work, saying your work is super vital and that she appreciated your expertise. So is there any question from either the panelists or the participants? I invite you to use the chat to ask your question. We have a question from Alana to start. I don't know if the panelists can see the questions. Maybe I'm not sure if the participants can see them all, so maybe I'll just read them out loud. All three panels discuss the prevailing ideology and judgmentalism around drug use that prevents discriminalization and other policy to achieve their objectives. For Lynn Beauchesne or any other panelists, so question to all of you maybe, do you see value in comparisons with other areas of decriminalization like abortion, polygamy, or even homosexuality? So does anyone want to pick up on that question?
I'll jump in right quick. I think to kind of like change it a bit, I see more of a safe supply conversation, say like the abortion pill, right? Where it was decriminalized for so long, people got, you know, and I think actually precedent was set in Halifax where they allowed people like the doctor to continue to prescribe it. But, you know, if people use drugs are not given a safe supply, we will find one, we will make one. There's such things as buyers clubs and whatnot. So I think we really have to, you know, look at some of the ways that we have changed legislation in the past, through abortion, through, you know, I'm not sure of polygamy and homosexuality, but, you know, I think there's avenues that we can take, and, you know, we got to look at the medical side of it as well. And that's what I really wanted to say to like abortion.
Thank you.
If I can add something.
Lynn? Mm-hmm.
Um,
Do you want to open your camera, Lynn, maybe?
Oh, I forgot. Oh, I forgot to start video story. Was just to say that when a practice exists, harm reduction is all the time the responsibility in front of this practice. What I wanted to say here is, if I drink milk, I have a preemption date, and I have somebody who look if it's really milk, if it's all safe. But on some issues, we're sort of in the 50s. Remember in the 50s when a young girl was pregnant, we hide this girl and we push them in the city. And instead of accompany that girl and go through and help prevent things that are not wanted and help things that happen. And I find that each time we are moral instead of harm reduction strategies to accompany and provide a secure environment. And it's why I like so much syndemic word. You know, the environment, the security of the environment is as important as the product.
Thank you.
I think,
Tiffany?
yeah, that is, yeah, really great. But I want to add, as like someone who has an anthropology background, that I do see a lot of overlap with things like abortion or polygamy or homosexuality. These are all like deeply entrenched cultural beliefs that impact how accepted these things are, and how accepted something is in a broad culture will reflect in political discourse, because politicians are always trying to get votes. So my idea and approach to, my approach to trying to move past like judgment and these more entrenched dominant beliefs, or to just talk about these things and their everyday facet of life, and to consistently educate people and elevate the voices of like people who use drugs and who are closer to the phenomena, to normalize what has been constructed as this like deviant and peripheral practice and position in society.
Thanks for sharing your thoughts, everyone. Thanks for the question. We have a question for you, Stephanie, from Catherine Larocque. Just wondering what the next phase of your project is.
Yeah, so the next phase of my project is what my thesis research is focusing on, and I wanted to figure out how these discourses impacted safe consumption sites operations. So I kind of figured that the people who worked in safe consumption sites were people who were in it for the good fight and would kind of bear the brunt of the policy change if it didn't, or if it negatively impacted care. So I made my target population to be the workers of safe consumption sites. And I'm currently interviewing people who work at safe consumption sites to ask like what their ideas about harm reduction are, and if the consumption treatment service impacts how they do their work, if it changes or if it exists in tension with their idea about harm reduction. And yeah, that's how I kind of I'm trying to get at the lived effect of the policy.
Great. Thank you. We also have some great feedback in the chat, and a question from Danielle Weinstock for Lynn. How do we determine intent to consume or traffic without using amounts as a proxy?
If you reverse the proof, now I'm a bit technical, but if you reverse the proof and you say that the police have to prove that this person is doing trafficking to make money, and if you don't have this proof, it's a user. That's it. And somebody can say, oh, we can make mistake. I prefer to make a mistake and to not have a trafficker in the judicial system than to make a mistake and have a user in the judicial system. It depends where you want to make your mistake.
Can I add on to that question? I think it's such an important question around thresholds and whatnot, right? So we have to realize that a lot of times people who are being criminalized for trafficking are people who are engaging in low level, day-to-day surviving of drug use. That's what I did, a middleman, right? So those are the people that are targeted and criminalized. I'm lucky I'm white and I'm a male, or I'd still be in jail or dead. I know I would. So if trafficking is not the problem, okay? The problem would be distribution, importing, production, like things like that, right? So, they would have to, like, the way I would look at it is like, okay, you have to have a judge sign off on a search warrant. You should have a live or like an advisory committee that goes through those cases to make sure that they're legit and that they are, actually have some, probable cause to search that person's place. We have to, like, the police say, the police aren't always running around solving murders and, catching high level drug dealers. The police mainly do give you tickets and, really low level stuff. We really have to kind of like focus our resources on not criminalizing people who use or sell low level drugs. Maybe look at what's coming into the country. But, I think it's really a supply issue, right? So look at the dark web, you look at large amounts that are coming in, and I'm not talking about ounces, I'm talking about kilos and above. And that's when I would say anything less than 100 grams, you're fine and you're good to go, because you put thresholds on it and it's going to be a Portugal model, and we don't want that. Or as someone who uses drugs, I don't want that.
Yeah, defining a threshold is definitely a tricky issue, and it's interesting if you compare to alcohol. We would never have the same kinds of thresholds, and we accept that people collect huge quantities of wine, but for drugs, things seem to be different. Thanks for that very interesting question and for the answers. Anybody else has a question?
I'm an open book. Ask away. You can't insult me. You can't ask a question that I've never been asked before.
Can I ask a question to Matt?
Go ahead.
Because I was happy that somebody is a bit critic on the Portugal model, because this model now is put on the sky like is the way we have to go, and you still have stigmatization. You still have a moral way of dealing with users. They still have to hide to not be catched by the police. And okay, in front of what is existing, they're the one with less repression. But they're not an ideal model. That's different. And Matt, what do you think about it?
Well, I think, yeah, you can't take a whole regulation process for another country and just implement it in your country and it's going to work, right? You need to talk to people on the ground, talk to people who use drugs, talk to the police officers, all stakeholders. You get them at the same table and you meet in the middle somewheres, right? I like that you brought up the stigmatization. Drugs will never be destigmatized until we decriminalize drugs. We put so much energy and time and resources in stigma campaigns and stuff, but then drugs are still criminalized. We have to flip that around, and there's, like Trudeau's I don't think he's going to decriminalize drugs. There's no silver bullet, he says, right? But nobody said there was a silver bullet to this overdose crisis, but it's one of the many bullets that, we have, or one of the 6 bullets that we could use. So we really have to look at a model. Maybe it's maybe it's city-based, maybe it's a Canadian-wide model. But, cops on the ground, B cops need to be educated in it, because we're seeing like the Good Samaritan Act, they're still implementing and enforcing. They're not implementing the Good Samaritan Act. So we have to look at ways where everyone, like the people that are actually going to be doing the arresting and stuff, are educated and they know what the policy is. And ideally, it would be someone who uses drugs speaking to them and telling them this, which may cause some controversy. But if we really want to look at a sustainable and effective way, that's the only way it's going to get done.
Thank you. We have a few questions now in the chat. First question is for Matt. Can you tell us a little more about the pathways of interaction between COVID-19 and toxic supply overdose?
Ooh, what a great question. There's the chocolate chip cookie analogy where, you make a batch of chocolate chip cookies, and not every chocolate chip cookie is going to have the same amount of chocolate chips. And so if you think about fentanyl, and where people are importing fentanyl and maybe it's pure fentanyl, then they're cutting it with different toxins, it's never going to be a smooth, like it's never going to, unless it's regulated and it's through it goes through extensive testing and whatnot, it's going to be inconsistent. Now, that happened prior to COVID. Now, what we've seen with COVID-19 is that now we have precursors that are being sent into our country, and chemists that have no experience with chemistry making the drug. So instead of the peanut butter or the peanut chocolate chip cookie analogy, it's like a peanut butter analogy that I heard. Before we had a smooth kind of steady supply of fentanyl that was coming from Mexico or coming from the cartels. Somebody probably pretty professionally was making it, and it was still very dangerous, but it was a steady kind of smooth supply. Now we have all these little batches that are coming out that are very toxic. I responded to an overdose I overdosed during the pandemic, and I responded to an overdose during the pandemic. And I can tell you that the supply has changed every time I use. But even when I responded to an overdose, almost a month ago now, what they used was so minuscule that, you would never think you would ever overdose off it. I didn't even have naloxone. And if anybody knows me, I always have naloxone dangling from my book bag, but I gave a kit to somebody that never ever had a kit right before. And I kept him alive with rescue breathing until the paramedics came. And, in the pandemic, that situation, people would be like, oh, well, does he, I was with 6 or 7 people, they all left except for one person. And that goes to show around the criminalization, how people just aren't aware of that they're protected in that situation, but not everybody is protected in that situation. So I don't blame them either. But, there needs to be education that, around, what does the Good Samaritan Act? We need drug checking big time. There's none in the land of Canada. There's no real comprehensive national drug checking strategy, and hopefully we will get one soon. And ultimately, we need a safe supply of drugs.
Okay, we have a question for whoever wants to take it. In a technical sense, would each province, like the recent promise for safe supply expansion in BC, have to implement their own guidelines? Or has the federal exemption extension under the CDSA had an impact on federal involvement with expanding safe supply on a Canada-wide level? Does anyone want to take up this jurisdiction question?
Go ahead, Stephanie. Are you going?
Bad time to open my mouth. Sorry, no.
So I think there's like safe supply right now is through a medical based model. Okay, so right now what we're talking about is like risk mitigation guidelines, pandemic prescribing. So really there is no jurisdictional stuff. If you have a provider that will prescribe you the safer pharmaceutical alternative, you can. The exemption really goes to allowing pharmacists to renew it, refill it, transfer your prescription, deliver it to you. So the exemption that is the Canadian-wide exemption that now is till next September is really for pharmacists. So BC has been able to implement a more person-centered safe supply because of that. But when we're talking about safe supply, until we get rid, like, there's only so much heroin that can be brought into the country that's already going to the Crosstown Clinic and now Victoria. They did increase the amounts a little bit, but it's not half as much as what the supply should be. But I think, you know, and even talking to Health Canada a lot on a daily, like we meet like pretty much weekly, you know, they're really interested on how safe supply really fits into this because they see it as a prescriber-based model right now. And that's what we have until we look at regulation of all drugs. And I don't think Trudeau, if he's not going to decriminalize drugs, he's not going to regulate them. So we need a more progressive prime minister.
And it's just to say in technical terms, is the same for tobacco, for alcohol, for the federal government is drawing the openings, what you can do, and is able to change the criminal law. But the investment and the way it will be done, it's to each province. And on health issues, it can just give permissions. After that is the province to decide where they will invest.
Right.
And when you have provinces like Alberta, we were seeing what's happening, right? They're taking their IO program, they're taking their safe consumption sites. So that, you know, to me, that's also like problematic, right? And because it's like safe consumption sites. We got none in Atlantic Canada, but the federal government's all for them. But that doesn't help if your provincial government isn't for them.
Mm-hmm.
Right. Okay. Stephanie, you talk about how drug users are often othered. Would you say that race plays a role in the othering and in the production of dominant discourses surrounding safe consumption sites?
So I think that the overdose crisis is still like opiates are still largely characterized as like a rural white problem, even though we know that that is not true. But you can't separate race from the overdose crisis. Like you just can't. There's huge portions that impact, or huge portions of Indigenous people who have been impacted across the country. So does it play a role in othering does race play a role in the dominant discourses? I would say slightly, because there are really negative tropes associated with a variety of races that involve the certain problematic uses of substances. But I can't fully speak to that. I would definitely need to look into that more to give a definite answer. Yeah.
Can I add something? It's just to say that, you know, we heard a lot that COVID-19 is striking blindly. Now we start to understand that it's not so blind, and to discover all the weaknesses in social programs that make COVID more here than there. And I think it's the same for the drug problems.
Absolutely.
Yeah, exactly. I think there was a super interesting reporting on how COVID-19 has struck on racialized neighborhoods in Toronto and in a way that it hasn't in white neighborhoods, obviously. Okay. Next question, I'm wondering from Catherine Larocque. I'm wondering if folks accessing supervised consumption sites feel over-medicalized. How are these services in terms of being aligned with the needs, wants, life ways of people who use drugs? Matt, do you want to?
I feel like Matt, yeah, could definitely answer that.
Yeah, so you know, safe consumption site and certainly consumption and treatment services are over medicalized. You look at Insight, where people who use drugs don't even work in the main room; they work outside in the chill room, and a lot of like things I'm hearing where, you know, at the sites, a nurse has to give naloxone, not a person who uses drugs. And I would argue, if unless you've been in a situation where you responded to an overdose, not in a traditional healthcare setting or even a safe consumption site, you should not be the one doing it. It should be somebody that has experience with it. Um, but you know, I think they're not meeting the needs of people who use drugs. We have one exempted safe inhalation site, which is insane. So now, you know, it's really hard to do these things and then go back and fix them. Or especially when we're talking about renovations that cost, you know, 20, 30,000, $100,000, it could be for inhalation. So I always like to use my one example. I used once at an overdose prevention site. Wouldn't even use at my local overdose prevention site that I helped start because of the stigma and the discrimination against people actively using. But I used at Moss Park's OPS. I bought drugs in Moss Park's OPS. It was a community-based model. Was that like on the wall, you can buy drugs here? No, but the feeling and how it was ran by the community, even though a nurse was there as leading it, she was back in the office doing her thing. So through that, it created a more safe environment, not just for me to use, but me to actually buy the drugs. I didn't have to go and give my money to someone who would have to go and get to potentially rip me off or getting into a violent altercation, or, you know, like who knows what happens. I've had all kinds of, you know, like weird things happen trying to get drugs. So, you know, by going to a site and being able to like just give my money to someone, watch them go and grab it and give it to me, you know, it was the most liberating feeling I ever had. I was more proud of myself, and that's probably when I really like started to come out as an open drug user, and that was in right before the pandemic really was global. I think it was like March 2nd or 3rd. I was in Toronto for a healthy city symposium, and I was just like, you know what, screw it. I don't care what people think no more. If they don't want to be around me because I'm a drug user, I don't want to be around them. And that's just kind of the, you know, philosophy I ever had ever since. And you know, it is hard. You kind of owe yourself, but at the same time, I don't use alone no more. I call somebody. I use with people. I'm not using as severely, or the relationship isn't as bad as it was when I had to hide it, right? So we really have to look at ways of treating people as people first. We all use some kind of substance. If it's caffeine or cocaine, they're all mind-altering substances.
Thank you. There's a question for you, Matt, from Victoria Young, picking up on the conversation you had earlier with Lynn on the Portugal model, whether it's what do you respond to people who believe the Portugal model is the only way? And also perhaps moving on, what type of model do you believe might work for Canada? That's a good question too.
It's a great question, and I hope everybody hops in on this. And hello, Victoria. I know Victoria, so maybe she's just poking me. But, you know, I think we can't look at Portugal as the only way, and it's really not the only, like, you know, I think it's just the most glorified and most romanticized model that there's been. Yes, they had a reduction in HIV. Yes, they had a reduction in overdose deaths. Yes, they had a reduction in all these things. But if you talk to somebody that went to the Portugal conference the Harm Reduction International conference last year, somebody died because they didn't have access to naloxone. It's not widely available there. Somebody tried to get drugs and almost got stabbed like right away. You know, so there's like that model is not perfect. We have to use some aspects of it, but we really got to tweak it to our local context. And to Lynn's point, there needs to be a federal blanket, but then each province needs to really get on the ground, get talking to the community-based organizations that serve people who use drugs, get people who use drugs at the table and ask them, how is this going to work? How are we going to educate police officers on, you know, safer drug use? How are we going to reallocate the funds? That's the biggest part. We can't just, we can't talk about decriminalization without defunding the police. We need to defund the drug war. And it's a tough, touchy subject for people, but the only way we're ever going to do it is to look at a population kind of health approach through community-based models and really decriminalize people and the substances that they use.
Yeah, we'll have to give two things to Portugal: the accessibility of services, and it's everywhere in Portugal. That is a plus. And the other thing in Portugal is one of the only country that to decriminalize, they didn't uh, do more punishment for possession for trafficking, or they were not harsh for the other aspect of the market. And in this aspect is good, but it's just to say that the user are still guilty. But I don't want to be a judge of that, because they're in the situation in Europe where if you're opening more, you will have thousands of European users coming in Portugal. Switzerland had this problem. Netherlands had this problem, and you must also take that in account when you're in Europe.
Thank
Yeah.
you. Yes, go ahead.
I just want to say one more thing about the Portugal model is that I think it is championed so often because it was the maybe not the first, but at least the most like well known because of the kind of progressive aspects it had to it. But like I believe it came out in, it was like 2008. It's been quite some time, and I feel like proponents of decriminalization kind of hold on to that. And it's similar with Insight, where like it was the most well known and quite successful for its time, yes, but it still has problems. And there's this kind of like fear of talking about kind of the things that like Matt was talking about in regards to like, you know, defunding the police and all the things that would be required to really decriminalize drugs. So you kind of like bring it back to, oh, look what Portugal did it. And well, they're still, you know, arresting people who have it for distribution. And, you know, you're kind of trying to make it palatable, but it's still then like the same like criminalization framework, because there are those obvious issues. And I think we need to just, you know, really be honest about what we need to see and not try to like placate prohibition values.